Hello everyone, I'm Dr. Abhijeet Kumar and today I will be discussing a clinical case. So let's start. A 20-year-old woman presents at the emergency department with severe abdominal pain. So she's presenting to the emergency department with severe abdominal pain on the right side with signs of internal bleeding. She indicated that she has been sexually active without contraception and missed her last menstrual period. Now, based on this information, which of the following disorders must be included as an option in the diagnosis? Now, before reading or before coming to the options, let us first understand what is given in the question. See, it says that a 20-year-old woman, remember the age group of the woman, it is in the reproductive age group. Reproductive age group, that is again very important. Apart from that, the complaints of the woman, she's having severe abdominal pain and that too on the right side with signs of internal bleeding. She indicated that she has been sexually active without contraception and missed her last menstrual period. So that again gives you some hint that she has missed her last menstrual period. Yes, I know everyone is thinking that it is pregnancy. Okay, agreed, it is pregnancy. Okay, so whenever such reproductive age group female comes to you with such complaints and she says that she has missed her period also, so in that case basically the history of last menstrual period should be taken from that patient or the female. Okay, and now coming on to the options. Now ovarian cancer, can it be ovarian cancer, guys? No, because in cancer there will be multiple components that should be given in the question. That is not given, and so this option is basically ruled out. Coming on to the next option, that is appendicitis. Now, reading out the second line that says that it is having severe abdominal pain. Okay, just if I read severe abdominal pain and internal bleeding, it can be appendicitis also. Okay, appendicitis also presents with the same symptoms as ectopic pregnancy. That's why I always say that ectopic pregnancy and appendicitis are differential diagnosis of each other. They are differential diagnosis of each other. Now, why it can't be appendicitis? See, the very first reason, the pain is on the right side. Okay, the pain is on the right side. Okay, it can be appendicitis also. Okay, now along with that pain it is giving the history of last menstrual period, so I will give plus minus to this particular option and will move on to the other option. Can it be normal pregnancy? No, in a normal pregnancy severe abdominal pain, internal bleeding is not there. Okay, so this cannot be a normal pregnancy because internal bleeding, severe abdominal pain is not there. There is abdominal pain occurring, but it is not severe. Coming on to the last option, that is the ectopic tubal pregnancy. Yes, this can be the answer. Why? Because she has missed her last menstrual period. Again, if we do a UPT, that is the urine pregnancy test, the pregnancy UPT will come out to be positive. Okay, and if the UPT will become positive, okay, that ultimately indicates that it is a pregnancy and that cannot be a normal pregnancy, I told you. So it will be an ectopic tubal pregnancy and it is the more best answer. This is the best answer amongst all the options that are provided in this case. Appendicitis can be there, but remember, along with the complaint, she is giving you a history that she has missed her last menstrual period. So the more precise or the more perfect answer would be the ectopic tubal pregnancy. Now, how to differentiate between a normal and an ectopic pregnancy? See, whenever a case comes to your department of any pregnancy, first you will actually do the UPT test, that is the urine pregnancy test. Okay, it is the urine pregnancy test, and in urine pregnancy test you will find that UPT is positive for both normal and ectopic pregnancy. It is positive for both normal and ectopic pregnancy. Still, you cannot differentiate. Now, after that, what you will do? You will recommend an ultrasound. In a normal pregnancy, what you will see? You will see a normal gestational sac, okay? You will see a gestational sac, or we can say intrauterine sac, okay? In the uterus. Normal gestational sac or intrauterine sac is present in normal pregnancy. You will find it on ultrasound. But in ectopic pregnancy, this gestational sac will be absent. This gestational sac will be absent. So that's one point of differentiation. By the help of ultrasound, you will be able to differentiate. But if suppose the patient comes to you like within 1 month, within 1 month, and remember guys, on ultrasound, within 1 month, true gestational sac never appears. So in that case, you won't be able to see the gestational sac on the ultrasound, and if you have not done the further investigations, you will classify it as ectopic pregnancy. So that's wrong. What you all have to keep in mind that even after doing the ultrasound, you get a gestational sac or an intrauterine sac, it's confirmed it's a normal pregnancy. But if you don't get a true gestational sac or an intrauterine sac, you will not call it as an ectopic pregnancy until and unless you get the beta HCG levels done. In normal pregnancy, what will be there? The beta HCG level, basically it will double in 48 hours. Whereas in ectopic pregnancy, it will increase but never double. That is a catch here. It will increase but never double. So in short, these are the points that you have to keep in mind while differentiating between the normal and the ectopic pregnancy. Along with these particular tests, you have the clinical symptoms of the patients that is associated with the ectopic pregnancy. Now, I hope all the options that has been provided, okay, you are able to differentiate and distinguish that how we came to the diagnosis. Apart from that, just let's discuss ectopic pregnancy. Ectopic pregnancy. See, this pregnancy is basically not occurring inside the uterus. Suppose this is the uterus, you know, it is the uterus. We have both sides, okay. I have just drawn only one particular side in one fallopian tube, okay. So normally the pregnancy is occurring inside the uterus. And suppose if the pregnancy is not occurring inside the uterus, it is occurring somewhere outside the uterus, that is in the fallopian tube, then it is called as ectopic pregnancy. Ectopic का मतलब होता है unusual, which is not present at its original site or location. It is occurring somewhere outside it, unusual. Okay, so the very first question, that is the most common site of ectopic pregnancy. Yes, yeah, it is the fallopian tube. It is the fallopian tube. Now, can anyone tell me what is the least common site of the ectopic pregnancy? Yes, it is cervical ectopic, okay, or ectopic in caesarean scar. Ectopic in caesarean scar, that is almost around 0.1%. So these are two important questions. That is, what is the most common site of ectopic pregnancy? Fallopian tube. The least common site of ectopic pregnancy? Yeah, it is the cervical ectopic or ectopic in caesarean scar. Now, can anyone tell me that this structure, it is basically of the fallopian tube? This structure, basically, it is of the fallopian tube. And what are the parts of the fallopian tube going from medial, that is from the midline, to the lateral? Okay, so what are the parts? Yeah, the very first one over here you can see with the black color. Yeah, it is the interstitium. Interstitium. The red one, yes, it is the isthmus. The blue one, that is the ampulla, guys. Yeah, it is the ampulla. And the last one, the finger-like projections are there. It is the infundibulum. infundibulum. Now I change my question and I ask you, what is the most common site of ectopic pregnancy in tube? In tube, basically we are talking about the fallopian tube now. If the question clearly mentions what is the most common site in the fallopian tube, yeah, again it is the ampulla. Again it is the ampulla. Okay, you know that ampulla, it is the site of fertilization where the sperm and the ova meets and in turn a zygote is formed. So that zygote is basically stuck inside this ampulla and will not able to travel further into the uterine cavity. Now what could be the reasons that this zygote is not traveling into the uterine cavity, or what is the pathology behind the ectopic pregnancy? Remember that Remember students that this zygote basically moves into the uterine cavity by the two process. Okay, the one process, the very first process, that is the peristalsis movement of the tube. Peristalsis का मतलब होता है rhythmic contraction और relaxation. यहाँ पे मसल्स होती हैं फेलोपियन ट्यूब की, ये रिलैक्स करती है, कॉन्ट्रैक्ट करती है, सो दैट इट पुशेस द zygote into the uterine cavity. Along with that we have the ciliated epithelial cells. Epithelial cells के ऊपर cilia लगा होता है, that also favors the movement of this zygote into the uterine tube. Now if suppose the peristalsis movement is not occurring properly, or if the cilia is not working, the zygote will not be able to move into the uterine cavity. It will get stuck there, and along with that, if I can simply say, if there is a blockage in the tube, if suppose there is any blockage in the tube, that will also not allow the zygote to move into the uterine cavity. So that's why the most common site of ectopic pregnancy, it is the ampulla. And remember, the least common site of ectopic pregnancy, it is the interstitium. It is the interstitium. Now can anyone tell me what is the narrowest part of the fallopian tube? Yes, it is the interstitium. Interstitium, followed by the isthmus. Followed by the isthmus. Remember, now this point is very, very important. In interstitium and isthmus, basically they are the narrowest part of the fallopian tube, the interstitium being the more narrowest one or the more narrower one. So here the ectopic pregnancy will end by the process that is called as the tubal rupture. Okay, the tubes will rupture. Since it is very narrow, the tubes will rupture. Rupture मतलब फट जाएगा tube. Okay, and the most common site for tubal rupture, it is basically the isthmus, followed by the interstitium. So the most common site for tubal rupture, पहले it is the isthmus part, followed by the interstitium part. Ampulla and infundibulum, basically the ectopic pregnancy ends here by tubal abortion. Since these are the crystal parts of the fallopian tube, and the most common site for tubal abortion, yes, it is ampulla and followed by infundibulum. Why I say it as tubal abortion? Because the ampulla region or the infundibulum region, the diameter, or they are much having more space over here, so that the zygote can grow, and ultimately it will lead to abortion. The tubes will not rupture in that case. Okay, so that is the sites for the tubal abortion, ampulla and infundibulum, and interstitium and isthmus being the sites of the tubal rupture. Now coming on to another very important questions that are being asked in the exam. So the ectopic pregnancy which lasts longest, that is the interstitium part, and after that it will rupture, and what is the time period after that it will rupture? It is around 12 weeks, and it is the most dangerous site of the ectopic pregnancy. Since why it is the most dangerous site? Because it is actually rupturing by 12 weeks. Now why? Since it is the smallest part and it is taking a lot of time to rupture. You will ask me guys why it is so. Because remember, in the uterus we have a muscle that is called as the myometrium. We have a muscle that is called as the myometrium. Now this layer of myometrium will actually support this zygote, okay, up till 12 weeks. So all the blood supply, all structural support is provided by the myometrium. Since it is attached to the interstitium part, that's why the ectopic pregnancy in the interstitium part will last longest up till 12 weeks, and ultimately when it will rupture it will be the most dangerous rupture, and that's why it is the most dangerous site of ectopic pregnancy. Coming on to the isthmus part, guys, remember the isthmus part basically it ends earliest and it ends by rupture via time period of 6 weeks. Okay, it ends earliest by rupture. Okay, and the time period it is 6 weeks. And coming on to the ampulla part, it ends by tubal abortion, and what is the time period for that? It is around 8 weeks. So these are the three potent questions that I have been discussed. Ultimately, you can put a dollar sign, as wherever I use the dollar sign in my lectures, I always say that these points are very, very important. Now, two most important, another question that I will illustrate with a dollar sign. What is the highest risk of ectopic pregnancy? Highest risk is the previous history of ectopic pregnancy. Okay, it is the previous history of ectopic pregnancy followed by any tubal surgery. Suppose any tubal surgery, okay, has taken place. So it is again a risk factor for ectopic pregnancy. There can be multiple risk factors also. Pelvic inflammatory disease. Now pelvic inflammatory disease, it is the most common risk factor. Pelvic inflammatory disease. Pelvic inflammatory disease, it is the most common risk factor, and in the pelvic inflammatory disease, the most common one, it is the salpingitis. Now you guys, everyone know that salpingitis basically it refers to the inflammation of this fallopian tube. Okay, salpingitis, inflammation of fallopian tube. So it is the most common risk factor that is associated with ectopic pregnancy. Along with that, the highest risk is previous history of ectopic pregnancy followed by any tubal surgery. Okay, so that is again an important slide where I have distinguished the time period and the risk factors. Moving ahead, what is the role of contraceptives in ectopic pregnancy? See, whenever contraceptives are taken, they usually decrease the risk of any pregnancy. But if they fail, or if they missed, or if they doesn't act, it will lead to it can lead to the failure of contraceptive agents can lead to pregnancy. That could be the ectopic pregnancy as well. So that ectopic pregnancy, so what is the most common failure of contraceptive agents which will lead to ectopic pregnancy? That is the tubectomy failure. Okay, fallopian tubes. Okay, what is the most common failure of tubectomy? The reason is basically it is the identification of the wrong structures in the surgery. So even if the tubes are not identified correctly, and it can lead to tubectomy failure as well. So apart from that, tubectomy failure, it is the most common one. Okay, and followed by the intrauterine copper devices, followed by progesterone only pills, followed by progesterone only pills. Remember students that intrauterine copper devices, in that also progestasert, basically it is having the maximum risk among the IUCDs, and copper IUCDs having the least common. Okay, so in IUCDs, so progestasert followed by Mirena followed by copper IUCDs, and the least chances are associated with oral contraceptive pills with vasectomy failure. Okay, so you have to remember that the tubectomy failure, it is the most common failure of contraceptive agents that can lead to ectopic pregnancy, followed by IUCDs, followed by progesterone only pills. That's again a question. That's why I'll put a dollar sign just to make you understand that this particular side is too important. Now, what are the symptoms of ectopic pregnancy? See, the very first symptom that was mentioned in the case as well, it is the abdominal pain. It is the abdominal pain. Now, this abdominal pain is differentiated accordingly. See, in ruptured ectopic pregnancy, what will happen? Basically, the tubes will rupture, and what will happen? The blood will go and collect, and that will lead to hemoperitoneum. And again, it will irritate the diaphragm and will lead to the shoulder tip pain in females. So that abdominal pain basically is due to collection of blood, and that is called as the hemoperitoneum. And accordingly, it will lead to the shoulder tip pain that is known as the Danforth sign, and that is seen in cases of ruptured ectopic pregnancy, whereas pain in cases of unruptured ectopic pregnancy is due to overstretching of the fallopian tube, and this overstretching of the fallopian tube will lead to unruptured ectopic pregnancy pain. And you know that unruptured is basically in two cases ampulla and infundibulum, whereas ruptured is in isthmus and interstitium part. Now in 50% cases, what complaints or what triad you will see, it is the amenorrhea that will be around 6 to 10 weeks. The patient will come, the woman will say that I have missed her, the last menstrual period was about 1 month or 2 months back. After that, the pain in abdomen, that is the classical symptom that we just talked about, and bleeding per vaginal. Now, suppose it is a case of normal pregnancy. In normal pregnancy, basically, you know, the progesterone basically supports the decidua. In ectopic pregnancy, the progesterone is present, but it is less in amount. So that progesterone will not be able to support the decidua completely, and decidua will start shedding off from the vagina. That will lead to the bleeding per vaginal in the form of decidual cast. So bleeding per vaginal can be there, cannot be there. So accordingly, majority in 50% cases, we will see this triad of symptoms. Apart from that, we will discuss the diagnosis and management. That is again an important part. So remember, whenever we are talking about the ruptured ectopic pregnancy, that is the interstitium or the isthmus part, that is the interstitium or the isthmus part, because in only these two parts of the fallopian tube, ruptured ectopic pregnancy will take place. See, so in that case, firstly, the UPT will be positive. Patient will come to amenorrhea with approximately 6 to 10 weeks. There will be pain in abdomen. Okay, the patient will be in shock. That's again a classical symptom. The BP of the patient will be decreased. Okay, the BP will be the patient will be in shock. It will be like systolic blood pressure would be like 60 or 50. Okay, and bleeding per vaginal, as I told you, it can be there and it cannot be there. Remember, ruptured ectopic pregnancy is always a clinical diagnosis. Okay, we never wait for an ultrasound to be done in that cases. It is always a clinical diagnosis, and the management is surgical management. Surgical management, we don't do any expectant management, any medical management, or any wait and watch for this particular cases. Okay, the only management is the surgical management that is done in these cases. So many of the time the questions will come and they will ask you what is the management in case of ruptured ectopic pregnancy. First you have to make the diagnosis, and after that you have to tell that it is the surgical management. Options will be there like medical management or wait and watch or see. It's not in case of ruptured. Oh, it has already been ruptured. Now what to do? We will do a laparotomy. We will give a big incision on the skin, and laparotomy is the preferred way of doing the surgical management. And what is the surgery of choice in these cases? Surgery of choice, it is salpingectomy. Salpingectomy. Remember, salpingectomy is the surgery of choice. What is salpingectomy? It is associated with fallopian tube, and tomy means to cut. To cut and remove the fallopian tube, that is salpingectomy. Whether it is a nulliparous woman, okay, a nulliparous woman, she has not given birth to a single child, or a multiparous woman, or any reproductive age woman, always we do salpingectomy. Okay, either she is married or unmarried or whatever. Salpingectomy is the surgery of choice in case of ruptured ectopic pregnancy. We can also do laparoscopy, but remember, for laparoscopy, vitals of the patient should be stable. Vitals of the patient should be stable. Okay, and majority of the times in ruptured ectopic pregnancy, the vitals are not stable, so laparoscopy is not preferred. Okay, so we do the surgery via laparotomy, and the surgery of choice remains salpingectomy. So that is in nutshell about the ruptured ectopic pregnancy. We have discussed the symptoms, clinical signs, all one-liners, and ultimately I have tried to give you a short information, okay, conceptual explanation about all the symptoms and everything that we have discussed. Thank you.